All right, we're recording.
Hi, my name is Shraddha. So we're doing the group discussion right now regarding different theories. So I work in a stroke unit, and I think Betty Newman's theory of prevention really is applicable towards my unit care setting. I think in our clinical setting, Betty Newman theory of prevention is really applicable. Betty Newman developed the Newman system model while teaching at UCLA in 1970. Newman system model is a nursing theory based on the individual's relationship to the stress, the reaction to it, and reconstitution factors that are dynamic in nature. Her theory gives a closer look at stressors in human life. Her theory is a holistic approach to nursing. It is based on a client's relationship with environmental stressors. It utilizes the use of primary, secondary, and tertiary nursing intervention for a patient's system wellness. There are 5 variables in her theory. They are physiological, psychological, developmental, social culture, and spiritual. This model is easily applicable in nursing practice, education, and research. Newman system model is an effective model which can be easily applicable in a stroke patient care since a stroke patient has a lot of stressors. Nurses have a key role in reduction of these stressors by applying prevention as interventions of Newman system model. By the application of this model, nurses are better able to apply their 3 level of prevention as intervention to reduce patients from stress. In the system model, prevention is the primary intervention, and it focuses on applying stress. It focuses on keeping stressors and the stress response from having a detrimental effect on the body.
Okay, so my question.
Great,
go ahead.
I'm sorry. So, hi, Tiffany. So, it looks like how a person reacts to a stressor can determine how well they may not heal. So, if nurses focus on a certain situation or part of the patient's situation, and do they address it and manage it accordingly, or how does that work, Shraddha?
So each case is individual, each case have their own stressors, and we just go by the Betty Newman's theory of prevention. We ask the patient their psychological needs, their physiological needs, emotional needs, social cultural needs, any stressors that can be handled by the nurse at the very situation.
All right. Well, my question is to you is like, how do you apply this theory in your practice? Like, can you give me an example or a scenario?
Sure, that's a great question. So I have a clinical example from my setting, which is a stroke unit. So I have Mr. K, who is a 67-year-old bedridden male patient who have a left-sided weakness, left-sided stroke. His past medical history has diabetic mellitus and hypertension. He had a complaint of pain in legs, weakness of whole body, numbness of right hand's finger. His CT scan showed ischemic changes, and he appeared depressed. In this case, there are multiple stressors that I'll be addressing. So the first one is a physiological. He has a pain. He's unable to perform daily life activities, difficulty falling asleep, psychological nervousness regarding daughter marriage, developmental age. He's 67 years old, and he's worried that he will not be able to work. Sociocultural wise, he does not have any friend circle at this state, so he's out of state. Spiritual wise, he's not able to perform his spiritual religious activity due to weakness. So applying the Betty Newman model of prevention, first regarding the activity intolerance, we can apply the secondary intervention provided by nursing intervention of assisting the patient in moving out of the bed, either with assistive devices like cane, walker, or crutches. For pain, regarding his pain, we can do the secondary and tertiary intervention by providing the non-pharmacological treatment like mind diversion, exercise, and medications. Regarding psychological stressor, secondary or tertiary intervention can be applied by allowing the patient to express feelings, moods, and behaviors. For sociocultural, secondary intervention can be applied encouraging the family to call patients' friends back home. And regarding the last one, the spiritual one, we can apply the secondary intervention provided by assisting and offering prayer or chaplain service. So this is actually a real case scenario. So after all this, the patient has a really good outcomes. The patient was satisfied and was very thankful regarding the nursing services at that particular location. So he was able to perform his religious activity and was able to vent out his concerns. And he was getting a little bit better by the time after we asked him all these questions and concerns. He was feeling emotionally stable. So I think Beatty-Newman prevention model is really applicable towards the stroke patient or in our setting.
Love the theory. Great in awesome. Your setting. Like I said before, I'm ER nurse as well, and I don't foresee this theory really working for us because we don't have the time. But I mean, if used properly and applied in practice, it seems like the patients will have great outcomes.
Right. Thank you.
I agree with that. Okay, so as stated earlier, my name is Tiffany Collins. Currently, I work in a long-term care facility in an acute care setting, which is a cardiac step-down unit in the hospital. So the goal attainment theory developed in the 1960s by Imogene King does describe an interpersonal relationship between the patients and healthcare providers of how the patient grows and to achieve their certain lifestyle goals. The goals should be measurable, realistic, and individualized for that patient. The goal focuses on personal, interpersonal, and societal systems that work together to present an optimal patient outcome. Some factors that can affect the goal include role, stress, space, and time. Goals depend on the patient's expectations, what's needed to achieve it. Nursing and healthcare providers work together to set goals throughout the nursing process. So how I incorporate the goal attainment theory into my practice. So when the patient comes into our facility, we have a process that's called baseline care planning. It's a meeting which includes the patient, family members, and or caregivers, depending on the patient's preference of who they want to attend the meeting, and an interdisciplinary team. So the interdisciplinary team includes participants from nursing, activities, dietary, rehab, social work, and the business office who come together to help identify patient goals and discuss how to work towards achieving the outlined goals through a holistic approach. So with that being said, as stated earlier, the factors that may affect the goals include the role, what role is the patient going to work towards reaching that goal, stress, how the patient reacts to the stress, is the patient able to use stress as a source of energy, motivation, or hindrance causing defeat, space identifies the territory and the surroundings, time involves duration and its relationship from one event to another. For example, completing something in a timely manner to go to the next project or jump the hurdle. Everything is a process. Using the nursing process and the goal attainment theory creates opportunity for the patient to achieve his or her goals. By using the steps of the nursing process that include assessment, nursing diagnosis, planning, implementation, and evaluation, a plan is set up to make decisions about how to achieve the goals and have a better patient outcome. If the goals have not been met, then the goals are reassessed, reevaluated, and new goals are set. So goals are different for every patient. As nurses, we provide encouragement to the patients and their families to create a positive environment to allow the patient the opportunity to work toward their goals. Some examples that might seem small to us, but could be major hurdles for patients. These are real life scenarios. Left-sided hemiplegia patient may get overjoyed because they can finally use a reacher to pick a sock up off the floor when several months before they weren't able to extend their arms or hands because of range of motion deficits. A patient unable to feed himself with a fork or spoon, pick up some finger foods, carry it to his mouth without dropping it, and a patient graduating from nectar or honey thick liquids to regular diet without choking or coughing. So my point being that no matter how big or small, goals are goals, they're achievable with the correct plan and the right work. So concepts relate to my practice through setting up baseline care plan meetings within the first 48 to 72 hours of admission, continuing the care plan process throughout the admission stay. Concepts, we do baseline care plan meetings. Nursing, nurses collaborate with the patient to identify and specify goals and problems. They collaborate and explore ways to achieve the goals. Health, continuing to adjust life stressors in the environment to achieve maximum potential of daily living. such as referring to therapy for any decline in previous ability to do something. Individual, every individual is different, therefore nursing has to ensure that we're including culture, beliefs, and customs to ensure that we're able to achieve their goals. Individualized care plans. Environment, how the patient has the proper resources to achieve their goals, such as safe environment on discharge, access to community support, resources, and pharmacy. Discharge planning begins on admission. Action, mental and physical behaviors, the mental action to recognize the current situation, what physical actions are needed to complete the actions to achieve the goal. Reaction, for every action there is a reaction. Educating the patients on the importance of being compliant with his or her medications, taking medications appropriately, keeping follow-up appointments, therapy exercises, and following a diet regimen that was prescribed by the physician. So incorporating the goal attainment theory into my present practice will continue to improve the quality of patient care to provide quality interactive nursing care to provide a better patient outcome. So the patient needs a support system, which could include the healthcare professionals, family, community, church, and social services to work towards achieving the patient goals. So Portia, I have a question for you.
Mm-hmm.
How does goal attainment theory reflect in your discussion on in your interdisciplinary team meetings?
All right, well, at my long-term acute care job, we have weekly IDT, as we call the interdisciplinary team meetings, with, of course, the nurses, providers, dietitians, pharmacy, wound care. These meetings are held on Tuesday, and we sit and we discuss the patient's progress, if they've completed a goal, what their next step is. But it's not just about us and what we think. We take the time and we speak to the patients on Mondays before the meeting so we can see how the patients are feeling about their goals and how close they are to achieving them. And then if they have achieved the goal, what they want to do next.
I have a question for you, Tiffany.
Oh, that's awesome. Okay.
So you said that you work in a long-term care. So the wound care is like biggest issue in the long-term care. So how often do you guys implement the theory in your practice? Like how often do you assess or make a care plan for the wound care for a patient?
Okay, so when a patient's admitted to the facility, we do an initial care plan. We do have a wound nurse who she measures the wounds weekly. We talk about the wounds every week. Wound assessments are done. Depends on what the doctor orders. He can order it once a day, he can order it twice a day, he can do it every 3 days. So it depends on what the doctor prescribes for that patient and what wound regimen they're on. So goals can be changed every day, or they can be changed once a week. It just depends on that patient.
Okay.
All right. I am Portia Toon, and I chose The Need Theory by Virginia Henderson. As both the ER nurse and a long-term acute care nurse, I wanted to choose a theory that I felt was applicable in both settings. And this theory is, Virginia Henderson believed that human need is the central focus on nursing practice. I too feel that our patients' needs are, our central focus, because in meeting our patients' needs, we facilitate recovery, independence, and getting discharged and being well again. The theory has 14 components. These components are: breathe normally, eat and drink adequately, eliminate bodily waste, move and maintain desirable postures, sleep and rest, select suitable clothes and dress and undress, maintain body temperature within normal range, keep the body clean and well groomed and protect the integument, avoid dangers in the environment and avoid injuring others, communicate with others in expressing emotions, needs, fears, or opinions, worship according to one's faith, work in such a way that there is a sense of accomplishment, play or participate in various forms of recreation, and learn, discover, or satisfy the curiosity that leads to normal development and health and use available health facilities. So I mean, in my practice personally, I feel that I apply this theory daily. Like if I have a patient who's having problems breathing, or if they have some kind of mechanical ventilation, I'm constantly checking that equipment to make sure that it's functioning properly, to make sure that my patient's been properly oxygenated. I'm turning my patients in the long-term care facility every 2 hours. I'm bathing them, I'm cleaning them, I'm dressing them. In both settings, I'm communicating with my patients. I'm asking about their needs, their fears, their concerns. And while I'm doing all of this, I'm teaching the patient, because Virginia Henderson also believed that the patient's needs needed to be met and they needed to be educated so that they could recover and function independently. She stated, "The unique function of the nurse is to assist the individual, sick or well, in the performance of those activities contributing to health or its recovery or to peaceful death, that he would perform unaided if he had the necessary strength, will, or knowledge, and to do this in such a way as to help him gain independence as rapidly as possible." So, that's my spiel on it and how I apply it in my practice. So my question to both of you is to give me an example on how you apply this theory in your daily practice.
I have to agree with you, Portia. The theory that you chose from the Henderson theory is a really universal theory. It can be applicable to any healthcare setting and any healthcare profession. I can definitely correlate my example, like of a stroke patient in my stroke unit regarding the need, because we have to make sure that the patient's concerns are covered while we're doing our rounding with the patient, like emotional basis, psychological, physiological, sociocultural, any needs or any concern that they have needs to be addressed. So, I mean, in that way, we can make the patient comfortable and, cover their needs. So I totally agree with you.
Yay.
And that's what happened to my stroke patient too, because as I mentioned on my example, like I had to talk to the patient about the emotional needs and his spiritual needs, so that we can cover his faith basis, like his spiritual needs. Yes.
Cool.
Thank you.
So I have to say that when you were talking about the need theory, I was thinking about our PAR meeting, which is Patients at Risk meeting. We have that every week. And in that meeting, we talk about patients who have weight loss, patients who have fallen, and what interventions we can put in place. We talk about patients that just have other problems such as breathing difficulties. And it made me really think about weight loss, because when you talk about your COPD patient or your patient that was on the ventilator before, who's having problem breathing, so a COPD patient actually is not getting adequate nutrition or concerning themselves with eating or drinking if they're having problems breathing. So that breathing needs to be assessed and addressed before moving forward. So I think that we really need to think more on that. And I will take that back to my practice because we don't really think along those lines when we're thinking about weight loss. We're more thinking about adding a nutritional supplement or trying to get their preferences and seeing if, they would like something else to eat. But if they're still having difficulty breathing, then that needs to be addressed first. The need of the ability to breathe needs to be addressed first, because they're not going to eat otherwise.
Yeah, I really feel like all of our theories just kind of go like hand in hand. Like, okay, so she went first and she talked about prevention, and then you go and you're talking about planning, and then here I am talking about taking care of me. So it's like, of course, prevention is what we want, but in the event that, things do happen, we need to plan and we need to take care of our patients' needs. So it's like all of our theories can be put into use, they all just tie into each other. It's pretty neat.
Right. I just have a quick question for you, Portia.
Yeah, I think so too.
Emergency unit is like very fast paced. So how do you do like a timely manner providing needs for these patients?
Well, I mean, you got to think about it. When the patient comes in on the stretcher coding, the first need I'm taking care of is their breathing, and then a lot of them lose, the ability to control their bodily function. So whenever, it's just like, in any other setting, when they're using the bathroom, I'm there to clean them. I may not turn and reposition them every 2 hours, but I'm taking care of their pain. A lot of them have concerns. They're concerned about what's going on with them and what's going to happen when they leave the ER. So I'm there to listen to that. So it's like you apply the theory in different settings. It may not be the exact same, cookie cutter way, but it's applied everywhere.
Right, that's true. Good example.
So I'm sure working in the emergency room, you really have to think on your feet. So trying to apply that need for therapy, that therapy need. Theory, I don't know why I say therapy, but the need theory can be a bit frustrating, I think, for me, because I've never worked in the ER. Just acute care, and it's a little bit less paced than that. So how do you deal with that?
Well, the ER is my home. I started there right after graduating, so I've kind of gotten accustomed to thinking on my feet. The main thing for me is communication. If the patient is able to communicate, and find out what their needs are. But if I have a patient who isn't able to communicate me, I have to use my nursing judgment. Like, does the patient look like they're in pain? Does the patient look like they're uncomfortable? And then, of course, family comes and we're able to talk to the family, look at the chart, see what their past medical history is and things that they've needed in the past. So, like I said, no two cases are the same. Quick thinking, nursing judgment, using your gut a little. Yes.
That's awesome.
Yeah.
All right. Well, I guess this concludes our discussion.
Finally, we're done.
Yes, I'm going to start recording right now. You ladies have a wonderful night. Just hold on.
Okay.